Awesome. Thank you, Andrew. So my name's Kavish Chandra. I'm a emergency physician here at the St. John Regional Hospital. And my rounds topic, I just really wanted to talk about some research articles that have come out that I think are worth your time to hear me out and make an opinion based on what you hear. We're going to keep the sessions interactive. So what I'm going to actually try to do here is, for those of you who have a smartphone, what I get you to do is that QR code, just open up your camera, hover it over that QR code. You'll see this kind of yellow box highlight, and then it says open a link to Slido. If you go ahead and do that, and if you don't have a smartphone or you don't want to use that, you could actually just type in that address in your web browser. And if anybody kindly wants to do that, they could even type that into the chat so people can just hit that link. So I'm just going to take a few seconds so everybody can do that. Any success?
Yep, it's working so far.
It's working so far. Awesome. Yeah. Great. So it's working so far. Obviously, I am still cheap, and therefore I didn't want to pay for the version that actually updates the poll results onto my actual PowerPoint in real time. So you can just see it on your web browser, and I'll talk about it as well. So we'll have a little bit of fun with it. So the first question is going to be to discharge your patient with tetracaine or not. What do I mean about this? Corneal abrasions. Some of you may have had them. You probably have looked after lots of patients who have them. And you use tetracaine to help you evaluate that patient because it almost gives them fairly instant relief of their pain. It allows you to evaluate whether there truly is a corneal abrasion or whether they might be something more sinister like a retained foreign body or a penetration into the globe. Nonetheless, when your exam is said and done and over, what do? You say goodbye to the patient. Here's some things to look out for. You may or may not get a follow-up with a ophthalmologist. And what I'd like for you to do is use Tylenol or some anti-inflammatory for your pain. And they said, but what about what you just gave me there? That seems to work really well. You say, nah, you can go. And your patient goes off, and you may have not had the opportunity to probably give them the best pain relief that they could. There's obviously reasons for that, but nonetheless, this paper actually tried to answer that. So Shipman et al. Published in the Annals of Emergency Medicine in 2021, short-term topical tetracaine being highly efficacious for the treatment of pain caused by corneal abrasions, a double-blind randomized clinical trial. So the objective of this study was to show that patients with corneal abrasions would experience more pain relief with short-term topical tetracaine than placebo. And how did they do that? They did a single-center, double-blind randomized controlled trial where they enrolled 118 patients with uncomplicated corneal abrasion. The intervention was topical tetracaine 1%, just exactly like how we use it. And this was after their evaluation, and discharged them home with a actual milliamp of the solution to administer every 30 minutes if needed for pain control, up to 24 hours, along with the prescription of a topical antibiotic. The comparison group was the same group, simple corneal abrasions. They left, but they left with topical saline drops that they would use for the same amount of time, up to 30 minutes, every 30 minutes for up to 24 hours, along with a topical antibiotic as well. And their outcome was measuring their pain at their 24, 48-hour follow-up, as well as secondary outcomes. They looked at hydrocodone use, as well as any complications. They included all patients over the age of 18 who presented to the emergency department, but they did exclude patients, and I think this is important to highlight, patients with contact use, ones who had surgery or transplant, ones who presented to the emergency department in a delayed fashion, if there's an infection, retained foreign body, if there's any penetration into the globe, or ones that required urgent ophthalmic evaluation, then those are pre-specified criteria for that as well. And what they found is that in the tetracaine group, at their 24, 48-hour follow-up, the tetracaine group had a pain score of 1 out of 10, whereas the saline group had a pain score of 8 out of 10. And which is a pretty stark difference. I mean, right off the bat, you say, gosh, obviously we know that this is a highly efficacious treatment when we use it in the emergency department. And when these patients went home after 24 hours, they found equally as so. So no surprise there. They also did show that their secondary outcomes were, again, this was at an institution where hydrocodone is used a little bit more than it is, say, locally, but fewer hydrocodone tablets consumed in the tetracaine group. So if anybody logged on late, this is just the QR code here to log on to Slido. All you have to do is have your phone over it, open that, or you could actually type this link into the box as well. And I think if you look in the chat, hopefully somebody has typed in that link as well. So the first question we have is, what are the cited complications of topical tetracaine use? And actually, sorry, I should say here, in terms of majority of the people do discharge patients home with 24-hour sample of tetracaine. So let me just figure this out here. Perfect. So the next question here is, what are the cited complications? Go ahead now. Go ahead and type in, what are the cited complications for topical tetracaine use? This is actually really fun for me to see on this, I guess. So right now we have a third who say delayed healing, a third who say keratopathy, about a third who say, I have no friggin' clue. And just for fun here, I mean, that was really just more of a fun exercise. But what I'm going to do is I'm going to stop that over there and we'll carry on. So in terms of the cited complications, delayed corneal healing is probably the most, is the one that's cited the most in short-term situations. And what this study actually found is there was no difference in the short-term complications of delayed corneal healing at their 24, 48-hour follow-up. And what they did is these are patients who were treated, they came back, were assessed by another emergency physician. And what they really looked for there was continued uptake of fluorescein, which is a marker of delayed corneal healing. And essentially there was no difference in the two groups. It was about 18% in the tetracaine group, 11% in the saline group. And again, that was a non-statistical difference. What this study is, it is important to note, is this study actually wasn't powered to look at complications, but there have been a number of other randomized control trials that actually have assessed the safety efficacy of tetracaine use in short-term situations for simple corneal abrasions. So at the end, what did this study strength-wise? They recruited patients 24/7 in their emergency department. All patients received a 1-week ophthalmology follow-up, although about 25% of those patients didn't follow up with an ophthalmologist, but they did actually make a concerted effort to follow these patients up on the phone. They hypothesized, you know how well it works. We know how quickly corneal abrasions tend to heal. These are patients who otherwise probably just carried on with their life because they were largely better. But they did try to make an effort to follow up on these patients, make sure that they didn't have any complications outside of their 48-hour follow-up. In terms of weaknesses, the study wasn't powered for rare complications, and we talked about that. The blinding. So like I said, this is a double-blind trial, but there's going to be limits to that blinding. Specifically, if you ever put tetracaine in your eye, you know it stings like hell for the first maybe 5-10 seconds. And after that, it's almost complete relief. Saline, I'm going to guess, probably doesn't have the same. The other ironic thing is these patients left with the little miniums of tetracaine. One of those that was required to give them relief for the 24-hour period, but to achieve the same amount with saline, they actually left with 4 little miniums as well. So again, somebody potentially could deduce that they may have been in the placebo arm as opposed to the actual intervention arm as well. And in terms of other weakness, like I said, 1/5 of these patients missed their 1-week ophthalmology follow-up. However, the authors do conclude that this study shows that short-term topical tetracaine is safe, efficacious, analgesic for acute, uncomplicated corneal abrasions. So we're going to go to the next slide here. Does this evidence change what you will do? And if anybody has any questions at this time, I think it'd be a good time to answer while we're just kind of seeing what the crowd says.
I'll just make a comment in that I've actually had ophthalmologists on the phone specifically ask me if I plan to give them tetracaine and then tell me not to.
Yeah. So Mandy, that's a great point. I mean, I would try not to get too far off topic. And I think that's going to be the biggest challenge is the advice from our consultants. I guess, you know, we could probably sit over a beer and probably debate all the variations of that statement that we've likely received. But, you know, in this situation, you're advocating for the patient. Sure. The studies to date have not been powered to look at the rare complications of keratopathy, which I think is what the most feared. I've had a number of ophthalmologists do cite the delayed corneal healing, but this is pretty good evidence to say that it doesn't differ substantially in this particular situation, whether you're giving them tetracaine or something other than tetracaine. So that's helpful for me. The ones that they warn us about hasn't really borne out in the literature, maybe in animal studies. And to that fact, probably there's actually ophthalmological literature that have used tetracaine for 24-hour, for up to 24 hours in patients with photorefractory surgery that ophthalmologists would have performed and found, again, no delayed healing and closure at 72 hours. So right there and then, you know, you have a randomized control trial, fairly large, done in the UK, that actually shows that, you know what, it's a different population. These are surgical patients that have an ophthalmologist looking after them, but nonetheless, they didn't have any significant horrendous complications as well. So what I think the group here really said is, yes, I'm going to consider short-term topical tetracaine as an analgesic. A handful said no, and some said maybe, but that's great. This is really just to kind of get a sense from the crowd.
Kavish, just to clarify, the question asked, does it change what you will do?
Oh,
it's quite interesting, because if 70-something% were already doing it, then the 22% is likely to not change what they're doing, which is to continue using it.
Fair enough. I could have made that question a little bit more clear.
Anyway.
Yes.
One question, one comment. The comment is in response to Mandy's comment, is that, funnily enough, if you ask the ophthalmologist what they would like, they all want tetracaine to go.
Yeah.
Like if they personally want it for themselves.
Yeah, exactly.
Yeah.
Yeah, if they had a corneal abrasion, they would want tetracaine to go.
Yes.
The question I had for this trial was part of the methodology. So when the patients were initially assessed for their corneal abrasion, did all patients get tetracaine to examine the eye? Because then if they went home with tetracaine or saline, the group that got the saline would know that they didn't get tetracaine.
Yes.
So it might over-report pain.
Yes. So good question. In all likelihood, they did. They don't say specifically in terms of how they evaluated, like how the individual physicians evaluated those patients, but they certainly did acknowledge that that stinging sensation would certainly clue a patient, any patient, into the fact that they're likely got tetracaine and not something else.
Could I add one more quick thing, just generally? I'll be really quick, Kavish. It's whenever you're asking a consultant something, it's still your responsibility to sort of evaluate what the level of evidence is.
Yes.
The studies that you've read versus the opinion of a maybe from a consultant, then I would even ask, why are we asking a consultant whether we should give tetracaine?
Yes, exactly. And I guess, I think Mandy's example is that in some ways it's almost anticipatory. They know in lots of circumstances we are probably, I mean, just from what we saw here, the patients are, and I guess it's, you know, they're asking a leading question in that sense as well. So, I
get it. It's just that it's not information I would always disclose.
No, absolutely. But an interesting, like I said, obviously generates a lot of fun. A fun chat with that as well. But I'm going to actually just move right on to the next one. So serial troponin testing. Are you testing your patients? So obviously outside of the 0-hour test for troponin in evaluating chest pain patients, are you repeating your next troponin at 1 hour, 2 hour, or 3 hour? And let me start that. In the Slido. Alrighty, so I'm just going to stop that there. Some people I think are having fun with me. They said, what repeat? But about 27-30% doing a 1 hour repeat, 9% doing a 2 hour repeat, but probably a majority of the patients, 55% of you guys are doing 3 hour repeats as well. So I'm going to stop that there, and we're just actually going to talk about this next.
Can I interject for a second, Kavish?
Sorry?
Yeah, just to clarify, I put the what repeat, but mostly because I don't follow a perfect algorithm every time. I kind of depend a little on the patient. I've got some super low risk ones that are less, they're 5 or less than 5, but they're not quite 3 hours in. I might just do a 1 hour repeat on them as per your guidelines. And sometimes I will, want to do a full 3 hour delta on someone I'm really worried about. So
fair enough. That's quite all right. That's quite all right. So this is a slide I just borrowed from another presentation that I did talking about what we use at our institution, which are high sensitivity cardiac troponin T assays as well. They've really distinctly changed over the last 10 years, such that we're using more and more across emergency departments in Canada, as well as all over the world. What high sensitivity troponin assays, just like their name would suggest, detect troponins at very low levels. Up to at least 50% of healthy individuals will actually have a detectable level. The specific assay that we use, and the one that's going to be used in the study that I talked about, has it characterizes a value at a minimum, I believe it's 3 nanograms per liter. Most patients are going to be, like I said, under the 5 nanograms per liter, and then the actual value above normal would be 14 as well. And as you can acknowledge here, because they're so sensitive, you can start to see a rise in these troponin levels in these patients who present with chest pain 1 to 3 hours after their repeat as well. And what this graph really just shows is the previous kind of conventional troponin assay, which was more like a yes/no binary type of situation, versus the high sensitivity. As you can see, that limited detection at the very lower part of it. And then you potentially may have a small ischemic event, you exceed that threshold of detection, or you may even have a large ischemic event, and you're certainly going to exceed that threshold. Which in this particular situation is why we do these delta repeats. And again, like I said, a bit of variety in terms of whether it be 1 hour, 2 hour, 3 hour. And as Paul pointed out as well, a little bit dependent on the patient as well. So what this study looked at was, again, published in SJRHEM in 2020, a prospective comparison evaluating the European Society of Cardiology 1 hour and 2 hour rapid diagnostic algorithm for myocardial infarction using high sensitivity troponin T assays. And what they did here is, they wanted to find out, is the 1 hour algorithm and the 2 hour algorithm essentially the same in terms of identifying patients with an MI. And what they really wanted to do, what they did is a single center prospective emergency department study in Canada, which is I think particularly important to highlight here, and recruited patients over a 2-year period. They had 608 emergency department patients that they included in their analysis, of which 350 had a valid 1 hour troponin and 550 had a valid 2 hour troponin. And what their primary outcome was index MI, so myocardial infarction at that visit. Their secondary outcome was major adverse cardiac event at 30 days. And they included all patients who presented to the emergency department over the age of 25 with the CDIS triage complaint of chest pain, cardiac features, and ones who required serial troponin testing. When I say required serial troponin testing, this study was done at an institution that they actually already have an algorithm that if patients presented, if they're deemed to be low risk, have an otherwise normal ECG, and who have their peak of pain greater than 3 hours ago, they are actually only doing a single troponin value. So you look and you say, gosh, 600 patients doesn't sound like a lot, but there's actually a significant amount of these patients who present at this institution who didn't even get repeat troponin testing because they have an algorithm that takes these patients right out of that part of it. So this is really only in patients who required serial troponin testing. It is important to note in terms of who did they exclude. Obviously, STEMI patients, ones with clear ischemic changes on their ECG, arrhythmias that weren't rate-controlled atrial fibrillation or sinus tachycardia, MI in the previous 30 days, or if they were unstable or had advanced chronic renal failure requiring renal replacement therapy. What they found was, with respect to 30-day MI, that whether the patients were evaluated with a 1 hour troponin or in the 2 hour troponin algorithm, essentially the rate of MI was the same across the two groups. In terms of their primary outcome, like I said, which was the index MI, again, more or less essentially the same. With respect to their secondary outcome, 30-day MACE, which is major adverse cardiac events, which include MI, revascularization, cardiac death, or the individual components of that. Again, there was no difference whether the patients were in the 1-hour algorithm and the 2-hour algorithm. And I didn't really, I guess, explain this. Patients, all patients who presented and were enrolled into the study for study purposes had a 0-hour, which is used obviously clinically, but they also had a 1-hour, 2-hour troponin. And if a physician wanted to have either 1-hour, 2-hour, 3-hour for the purpose of the evaluation of their patient, they never had access to the 1-hour, 2-hour results of the troponin. That was only done for the purposes of the study, if that makes sense. In terms of the study validity-wise, it is externally valid. It's a Canadian emergency department, large volume, similarly like ours. They did consecutively recruit patients. And like I said, they did blind physicians, treating physicians to the 1-hour, 2-hour values that were used for the purposes of the study. They adjudicated all outcomes, whether those were MI using the third universal definition of an MI, as well as the actual components of the MACE score. One thing, I guess not one thing, but probably the biggest weakness of this study, it only included chest pain patients with the triage complaint of chest pain, and systematically may have actually not included patients that don't necessarily always present with chest pain, but are high risk for having myocardial infarctions, specifically women, geriatric patients, and patients with diabetes. So, and as well as a smaller sample size. But what the authors do conclude is whether you use a 1-hour or a 2-hour repeat high sensitivity cardiac troponin T algorithm, they function essentially the same in ruling in or out MI. So this is just an example of what the Calgary zone emergency departments use in terms of their algorithm as well. I actually forgot, I was actually going to take this out because I knew we'd be close to getting out of time. So just forget that. I'm going to take those out. And gosh, now I'm gonna think about what Paul said. The next question is, does this evidence change what you will do? Again, just more for fun, just want to get a sense of, hopefully, yeah, this is a little bit more clear. So are people going to maybe potentially change to a 1-hour algorithm? Are they going to stick with their 2, or they're good with their 3-hour? Any questions so far while we're just waiting for a few of those answers? And I think, can you guys see those responses as well?
Yes.
Perfect.
Okay, well, I might have missed what you said. Are we using that specific highly sensitive trope now at the regional? And
we are using, I don't know if it's like, for example, like the one from the exact same manufacturer, but we are using a high sensitivity troponin that has a very similar cutoff. It has in terms of its limit of detection, I don't know what ours is. I don't think it's readily available when we order it, but in terms of the 5, less than 5, that's the other one that were reported as well. So it sounds like it's very similar, but it may not be from the same manufacturer.
thanks.
Just wondered if it's an increase in the blood test per unit time, and we never do these tests exactly at 1 hour, 2 hours, or 3 hours, why aren't we looking for a ratio rather than a number? Because
so that is a really good question. I guess the only argument I heard with the ratio is that because now these troponins are so sensitive, James, that so for example, in this study, and I didn't talk about in terms of great detail about it, but a delta less than 4 in the absolute value, so that's what they used to be. So there's going to be inherent difference in terms of the assay, not just because of the timing, but that can certainly contribute, but actually inherent error in the assay itself. A delta less than 4 is what they were using in this study. It's probably what they use in other studies of a similar type as well. If you use a value of percent in these very small situations where somebody might have a absolute troponin value of 6 and it goes up to 9, it's going to potentially miss out on those people who have very small values, who might end up in an observational zone. When I say observational zone, those aren't patients that are necessarily good. They're done. They're low risk. they're going to get put into our low risk algorithm based on a clinical score or whatever it is that we're using. So that's the argument of not using an actual a ratio or a percent, but actually using the absolute delta value.
Thanks.
Perfect. So interestingly, most of you say here, bring on the 1 hour algorithm as well. So like I said, just really to introduce the idea as well. It's just interesting to see what everybody responded with as well. So I'm going to go to the last one now here. So the last study here is DVT diagnosis with D-dimer adjusted probability. So if you kind of look here, this is, I think it's a roulette table here, but for me, this is what sometimes the workup of a DVT feels like. It's diagnostic testing for deep vein thrombosis requires multiple steps. It's time-consuming process where you're trying to coordinate an ultrasound, anticoagulation therapy. And we know that these are patients who absolutely need therapeutic anticoagulation, if not after the diagnosis, certainly before the diagnosis is confirmed. A negative D-dimer in combination with a low clinical pretest probability is how we really exclude these patients. So the Wells DVT score. Patients, otherwise you get ultrasound imaging to evaluate these patients. And that is how we typically, that's typically how we assess these patients. What this study actually did is, and I do want to highlight that this study is actually a conference abstract, but what they actually did is it was presented at the American Society of Hematology, their annual meeting just in December of 2020. The study isn't published yet, but it's looking at deep vein thrombosis diagnosis with D-dimer adjusted clinical probability. And what their objective was to evaluate the safety as well as the efficiency of a diagnostic algorithm for DVT that was designed to minimize the need for ultrasound imaging by using a clinical pretest probability based D-dimer threshold. And I'll talk a little bit about what those thresholds were to really exclude DVT rather than the standard fixed D-dimer cutoff, which is probably what a majority of us are using at our institution as well as institutions across Canada as well. What they did is they enrolled patients across multiple institutions over Canada over a fairly large study period, 2014 to 2020, and they enrolled over 1,500 patients with signs and symptoms of DVT. And what their outcome was symptomatic venous thromboembolism, whether it was a proximal DVT or PE, within the 90-day follow-up period as well. So patients who went into the study were assigned a Wells score. It's the same way, low, moderate, high risk. And then with those Wells scores, they actually had adjusted D-dimer cutoffs. So for example, if they went into the low risk category based on their clinical pretest probability, their D-dimer cutoff was less than 1,000 nanograms per liter using their specifically D-dimer assay. If they were in the moderate pretest clinical probability, then their D-dimer cutoff was now less than 500. And if they were under that threshold, they did not get an ultrasound and they did not get any anticoagulation, and then they were just followed out to 90 days. All other patients, so patients who had a high pretest clinical probability, or ones that were low but had a greater than 1,000 or moderate and greater than 500 nanogram per liter D-dimer value, went on to have a proximal DVT ultrasound. And in this abstract, what they showed, in the abstract presentation, showed that 11% of patients had DVT on their initial visit or that subsequent 1-week follow-up ultrasound. Of the negative patients that had, of the negative patients who are deemed to be negative based on their clinical pretest probability, as well as their adjusted D-dimer cutoff, 0.5% had a venous thromboembolism within the 90-day follow-up period. But the interesting thing is in the low risk, in the low Wells, but less than 1,000 D-dimer cutoff, or the moderate and less than 500 cutoff, they actually had a 0.4% incidence of venous thromboembolism in their 90-day follow-up. And really what this ultimately amounted to is fewer DVT ultrasound studies in the clinical pretest probability plus D-dimer adjusted algorithm group as well. So like I said, this is just a conference abstract. This study has not been published yet, but the authors do conclude that this new algorithm can rule out DVT safely while substantially reducing requirement for ultrasound imaging. So we're awaiting the published results, and I'm just going to end right there here with the last question, and I'm going to move on. Is anybody interested in reading the study when it's published? And if anybody has any last minute questions, I'm not going to take up too much of Mandy's time. But if you have any questions, we'll see what the answers show here. Yeah, so people are interested. That's great. And I think other people just want to hear Mandy speak now.
I think there's another study in the past couple of years too that had a similar cutoff for PE studies as well. So they kind of use 1,000 for low risk patients and 500 for others. And I think they followed them out either over 30 days or 90 days. And it was equivalent kind of results that it was really, really low risk and they didn't really miss any clinically significant pulmonary embolisms. I can't quote you the exact journal.
Yeah,
but
yeah,
it was something
no.
I listened to recently.
Yeah, and I wonder, I mean, I guess Chris or maybe Rachel might know, because I know they obviously looked at quite a bit of detail. Is that the Adjust PE study or?
I think so. Yeah, there was an EM cases review of it.
Yeah, and there's obviously, did they talk about age in this one too, Kavish, or was this just basically just the cutoff?
This is just cut off based on that, the Wells criteria.
Okay.
Yeah, I mean, age is another interesting thing, but yes.
Well, their topic.
Another topic, exactly.
So I've just briefly stepped in lieu of Peter as facilitator and hand her over here. So I want to thank Kavish for that very interesting presentation of how research can perhaps challenge what you thought was cast in stone. Everybody hates the D-dimer, but maybe there's a use for it. You know, you've always been told not to put tetracaine in the eyes, but maybe it's okay. I think this is wonderful, challenging what we believe to be true.